Every day, thousands of people experience loss of loved ones, serious injuries and illnesses, frightening accidents, physical and sexual abuse, neglect, violence, and other types of potential traumatic events. Evidence shows that trauma during childhood can cause serious, immediate emotional and physical harm to children and their families, which persist through adulthood. Trauma survivors experience higher rates of suicide, depression, anxiety, and substance abuse. They are at greater risk of developing visual, auditory, and tactile hallucinations, as well as psychotic symptoms and post-traumatic stress disorder. The lifelong effects of trauma can result in vulnerable hospitalized patients exhibiting negative coping strategies, for instance, self-destructive behaviors or aggression towards others. In order to manage patients' symptoms, staff training can greatly contribute to recognizing and understanding the chronic and devastating effects of trauma on one's overall functioning. Trauma-informed care places emphasis on individual choices and empowerment through a collaborative effort, thus making the patient feel less vulnerable and more in control of their symptoms and feelings. Dr. Joan Gillies, the director of the National Center for Trauma-Informed Care, and Dr. Timothy Tunner, consultant and trainer for the National Association of State Mental Health Program Directors, have been recognized as trauma-informed care experts. Their training to hospital and mental health staff have been instrumental to create cultural transformation due to the implementation of trauma-informed care principles. Let us now join Dr. Gillies and Dr. Tunner.
I come to you bringing you this message of trauma-informed care not as academic or what the literature shows, but somebody who has really walked in the same shoes that you are in and is really clear, I'm very, very clear, that if we institute some of these practices that we're going to talk about today, we're going to create environments of care that are safe for you, which is critical, as well as safe for those that we serve, okay? By creating systems that are trauma-informed, we do no more harm. And I can't stress enough how much we are committing to reducing the likelihood of violence in your lives and reducing the likelihood of trauma in your lives, because we understand some of the practices, takedowns, the violence that can occur on the units are traumatizing to the staff too. So we want you to keep an open mind. This isn't the new technique of the week. This isn't the new intervention that you have to learn and learn how to chart. This is a culture shift. This is really a culture shift that looks at understanding how some of the symptoms that you see that some of the patients exhibit are actually adaptations to trauma. We're going to talk a lot about that. Another take-home message, one of our colleagues and friends, Dr. Sandy Bloom, she's a psychiatrist in Philadelphia. She also says, hurt people, hurt people. Okay, symptoms as adaptations, hurt people. And what a difference it makes when we start to look at the patients that we are serving and say, what happened to you versus what's wrong with you. When we're talking about trauma, this is what we're talking about. We're talking about that experience of interpersonal violence, and that can be anything from physical abuse, sexual abuse, emotional abuse, abandonment, neglect, okay? This is what we're talking about when we're talking about trauma, and it is pervasive in the lives of those in your care. Okay, and we'll talk a little bit in a minute about how pervasive it is in the lives of people that come in contact with you in the facility. But what makes something traumatic is really how the person responded to it. Sometimes people will say, well, that happened to me and I'm okay. Well, how it was addressed, how the person responded, what happened when they told. We often hear from people that have trauma histories that when they told, they were hushed. When they told, they were said these secrets remain in the house. When they told, they were told that, what are you doing flirting with my boyfriend? They were told that, what are you doing? You're seducing that person. So what happens when you told is significant. You often think if it was your own kids and you knew they were being abused, you'd be all over it, right? But oftentimes those that we're providing supports to through whatever, through their inability to communicate properly, through their inability to get that kind of comfort they needed, weren't able to be soothed. Some interesting research, a gentleman by the name of Dr. McKay Vernon did some research on people who were deaf and receiving mental health services. And he found that over 90% of deaf individuals receiving mental health services had been the victim of sexual abuse. But you can imagine that, a perfect target, right? Growing up, if you can't communicate. So we're looking at, it's really important to find out what happened when they told. And did this experience result in that feelings of horror and fear and the risk of losing your life? What happened when the person experienced the trauma? The trauma, it's usually not a single blow. It's usually not one disaster. The people that we're talking about frequently had traumas that were repeated, severe, and prolonged, and frequently occurred in childhood and again repeated through adulthood. And what we need to think about is some of our practices. For example, if we know that the prevalence of trauma is pretty high in the lives of people that are in your system, we know it's high in lives of people in the criminal justice system, we know it's high in the lives of people in the homeless system, and that's who comes here, right? You get people that have had that intersection with all those different systems. What do we think it does when we have to tie somebody down? Particularly a woman who has been the victim of rape, and we're putting them in 4-point restraints. What we hear from people was that was so re-traumatizing. So we need to reduce the likelihood of having to do that intervention in the first place. Trauma-informed care is prevention, prevention, prevention. Trauma-informed care intervenes at the stimulus level versus what we often do is the response level, right? So we want to create an environment where we're reducing the likelihood to have to do that intervention in the first place. As I said, symptoms as adaptations, okay? Looking at some of those behaviors that you see as adaptations to the trauma, okay? Think about substance use. Think about people on your units that you're doing the, for co-occurring disorders. How much is substance use in this population self-medicating? You know, you're not finding a lot of the people that you're serving using to go out and party. You know, that's not what's happening. When you look at when the use started and you look at when the abuse was happening, you look at when the psychiatric issues were starting to bubble up, people were using to numb out. People were using so it wouldn't hurt so bad. People were using to make the voices stop or whatever. So substance abuse really needs to be looked at in this population as self-medicating and as a coping mechanism for people who perhaps it's the best coping mechanism they know. Okay, so it's really important that, that we look at that. Some of the symptoms of trauma, I'm sure you guys have all seen these. Self-inflicted violence, cutting, we're going to talk about that in a minute. Addictive behavior, impaired attachments. How about anybody work with somebody who did that warmth by friction, that person kind of that drove you crazy, that was in your face all the time and needed that connection but did it in such a way that was so annoying? Okay, yeah, you've never had anybody like that, right? That warmth by friction can oftentimes be the only way a trauma survivor in some ways knows how to respond. Interpersonal skill deficits. Imagine if you're a child, for example, and you're being abused, particularly by a family member or a trusted community member. How do you trust? You know, how do you trust? Are you always on edge? Or are you always wondering what's going to happen next? Are you very paranoid? Okay, so just some of these symptoms as adaptations. Everybody's worked with people that cut or swallow or hurt themselves, okay? And we often think that this is attention-seeking, manipulative behavior. Well, it's not. It's not. And what we know from people who self-injure is that it frequently is a way for people to connect with their own feelings. It's a way for people to control externally what they can't control internally. It oftentimes gives people relief. And interestingly, it's not suicidal. We hear from people that self-injure that it keeps them from killing themselves. Okay? It's a really tough thing, and I see it so much in these facilities that we visit, whether it's criminal justice, juvenile justice, in the mental health system. There's a lot of people cutting. And that's what we have learned that it's really about. It is not an attempt for, you know, for attention, and people are often shamed and blamed for self-injury. You go to the ER with someone who's hurt themselves, and they are not treated with open arms. You know, it's almost disdainful. So it's really important for us to think about that. Almost always, self-inflicted violence is a result of trauma. Almost always. Okay? People say that it diminishes intense anxiety, it can prevent flashbacks, and it helps people maintain control. Okay? Dissociation, you've worked with people who are just spaced out, right? You can't get through to them, they're going someplace else. Frequently trauma reaction. You've heard of dissociative identity disorder, people with multiple personalities. Think about it from a trauma perspective. Think about a child who's being abused. Is it self-protective that you go someplace else? That you're able to put your mind someplace else? That you develop these different personalities? So think about that from a trauma basis, and think about how many of these symptoms that we see in our patients are really adaptations to the trauma. Okay? Post-traumatic stress. We hear a lot about this, you know, from the war in Iraq. And one of the stories that I think really brings it home to me was in the Washington Post, there was this article about some troops coming back, and they were all living at Walter Reed. You've all heard about Walter Reed and the things that are going on there with the returning troops. And on the front page of the Washington Post, there's this picture of this adorable 22-year-old kid who had both of his arms and one leg blown off in the war. He's living in, at Walter Reed, and down the hall from him is one of his buddies that he was in combat with. And he committed suicide. He palmed his meds and committed suicide. So with all good intention, the military loaded these kids up on a bus and took them to Arlington Cemetery for a proper military burial. So after the service, what they didn't know was going to be re-traumatizing was when they shot off the cannon. Oh, and the kids are in the fetal position. Make it stop, make it stop. All good intentions, all good intentions. But what it did, post-traumatic stress, re-traumatized everybody. And sometimes that's what happens in our facilities, with us not knowing it. Sometimes some of the things that we do with all good intention are re-traumatizing to people. And that's what we really want to take a look at and help our patients, help us understand what are those triggers for them. Because believe me, we've done this in a lot of hospitals, and the staff and oftentimes the patients aren't really in touch with what really is it that's triggering them, because sometimes it isn't that logical and it isn't that straightforward. So we want to make sure that we're not setting off those cannons in our own facilities. So post-traumatic stress, most people aren't diagnosed with post-traumatic stress. You know, you're going to see a lot of trauma-type diagnoses that might be more affective disorders. You might see a lot bipolar, depression, personality disorders. But a lot of people are not diagnosed with post-traumatic stress, and it's only more coming up more frequently recently. But people with PTSD have these intrusive re-experiencing. They think that it's going to happen again and again, okay? Avoidance, they work hard to avoid anything that's going to remind them of what happened and of that early trauma. This is oftentimes where the use of drugs and alcohol come in. People use in order to not experience those flashbacks again. They avoid. Arousal, people are oftentimes in that hyper-arousal state, wondering what's going to happen next. They may seem constantly on guard, okay? They might be hypervigilant. And to be in an environment when there's that fear of violence, and you're constantly on guard, and you're constantly what's going to happen next, and you've just been involved in taking somebody down when you don't know what's going to happen, is really scary, and it really can keep you in that hyper-aroused state. Trauma-informed care works to prevent that from happening, so you are not affected by it. So you are not affected by this experience of having to not know if you're going to witness violence or be involved in violence on your work day. No one should have to work like that, and that's what we're trying to prevent. Traumatized kids, almost all the abuse with kids happens at the hands of a trusted family member or a trusted community member. And what's so difficult for children is oftentimes the very person that they can go to for soothing is the person that was abusing, okay? So they're often in that hyper-aroused state and are particularly unskilled at self-soothing. You really think a lot about diagnoses with kids. Juvenile justice system, the girls that we work with, every single one, ADHD. Every single one. Bipolar, they're all bipolar, but a lot of those diagnoses, I bet if we carefully examined where they were coming from, we'd find trauma and would find a lot of these behaviors. So the diagnosis is going to the behavior versus the underlying causes. So that's what we're looking at. How can we address these causes? And when we do trauma-informed care, things change. The juvenile justice in the girls' system, we did a whole training with the officers. They learned the prevalence of trauma in the lives of these kids. I said to them, when do you have your highest incident takedowns with these girls? Well, it's in the morning when the girls have to get ready for school and they go into the laboratories. We always do a takedown. There's always somebody getting taken down. So I said, well, let's go in and look at the environment and try to figure out what in the world is going on here that should be such a volatile time. So sure enough, I go into the bathroom, and there are no doors on the headstalls. There are no shower curtains, and staff is watching them get dressed. Now, if you're even if you're not a trauma survivor, can you imagine getting a little agitated by that? I would. So the staff brilliantly came up with this idea to hang curtains, but that are Velcroed. So if somebody tries to hang themselves, the curtain will fall down. This was empowering officers to make these decisions and to move in the direction to reduce the likelihood of them having to get hurt also in the morning and to reduce the likelihood of triggering those girls. We're trying to create an environment that is more like a place of healing and more like sanctuary than it is like a place where people are being punished, which will make the staff happier and will clearly help the patients, help the patients on this road to recovery. Everyone has something to offer this place. People have told me when I was here last time, this guy's an amazing artist, look at what he does, and this one can really play music, and there's great strengths. But what if we asked the patients, what if we did on a mission, what if we said, tell us what you can bring to this unit, tell us what you do right. I think we'd find some amazing things if we just said, tell us what's your strength. We're dealing with very, very wounded spirits. We're dealing with people that have failed and failed and failed and hurt. We're not dealing with people that are feeling really good about themselves, right? What can we do to try to bolster that up, and which indeed will make your job a lot easier. Trauma and attachment. I mean, clearly people with trauma histories have problems attaching. So you can look at the intergenerational issues of trauma. We know that attachment is critical for children growing up to go through these important developmental tasks that lead into healthy adulthood. If you have a traumatized parent or several traumatized parents, or you're going through these issues in the home, you're not moving through those developmental tasks that are so important in healthy adulthood. So attachment, you hear in the juvenile justice system, attachment disorder all the time. You hear all these kids being diagnosed with these attachment disorders. Trauma-based. If you take it down, you're going to find trauma at the basis of all that. So it's so important for us to address the trauma so we can help people heal.